Good afternoon. I'm here to talk today about universal genetic testing, challenges and opportunities. It's been a remarkable time over the past decade in the field of oncology, and particularly in genetics. We are moving toward a real precision medicine setting, moving from, as you can see in this older time, a one-size-fits-all medicine toward a more stratified medicine, which is where we are today, with patients grouped by disease, subtypes, demographics, clinical features, and biomarkers, toward this dream, this vision really of precision medicine, whereby we personalize our treatment by patient and individual preferences, by clinical features, medication history, environment, behaviors and habits, and of course, the genetic biomarkers in the tumor and the germline that I'll be talking about today. So with this exciting change and this new genetic and genomic technology come opportunities to characterize risk and optimize treatment. However, with this, of course, also come challenges, and these include questions of accuracy in terms of genetic and other biomarker-based testing, clinical utility in terms of whether this new information that we gather is useful for patient care, implementation, how good a job we do of putting it into practice, and disparities, how fair this is between different groups in the population. So a major advance in genetic testing is the technology of next generation sequencing that's shown here in this cartoon, starting with double-strand DNA toward fragmentation and size selection, down toward ligation and amplification, with the result being that it is a massively parallel processing where one can sequence many molecules of DNA at the same time. And because of that, it is much faster, it is much cheaper. And its implementation has really been facilitated by changes in the regulation and also the patenting of genetic testing over the last decade that has allowed us to bring this technology to our cancer patients and their families. So we have found in our research looking at real-world implementation of this kind of new next-generation sequencing technology that it has rapidly replaced older ways of testing patients. So this is from a study we published earlier this year where we looked at population-based data from cancer registries in Georgia and California, looking at women with breast cancer who were getting genetic testing for inherited risk. And what we found was that back in 2013, only about 8 years ago, when people were getting genetic testing for cancer risk, the most common thing, 70%, would get a test for only 2 genes, BRCA1 and BRCA2, really the best known hereditary breast cancer genes. But quickly over the next 4 years, we see a replacement of that single or double gene test, BRCA1 and BRCA2 only, being replaced by multiple gene panel testing, being tested for many genes, upward of 100 in some cases. And you see that by 2017, 4 years ago now, only about 15% of patients were being tested for a more limited test. Most people were getting the works, large multi-gene panels to understand inherited cancer risk. And so there has been movement in our practice guidelines as well. These are guidelines from the National Comprehensive Cancer Network, but there are certainly other guideline organizations also, American Cancer Society, American College of Medical Genetics. And you can see that there has been an attempt to define strategies for managing cancer risk that are adapted to the level of risk with inheritance of pathogenic variants or mutations in these various genes. So for enhanced breast screening with breast magnetic resonance imaging, we see here this list of breast cancer genes, all of which approximately double the risk that a woman develops breast cancer, some of them much higher, BRCA1 and BRCA2, with up to 5-fold risk increases. We see that many genes here increase the risk of developing colorectal cancer and are reasons for earlier and more frequent colonoscopy or endoscopy. We see that some of the really high-risk breast cancer genes, these 6 on the list here that approach a 5-fold increase in breast cancer risk, are grounds for discussing risk-reducing mastectomy as an option, not recommending it explicitly because screening is still a good alternative, but per guidelines, discussing it as an option. Risk-reducing salpingo-oophorectomy is recommended for women with mutations in these genes that confer a high ovarian cancer risk, and there really is no good alternative for screening, so we do have to recommend risk-reducing surgery to remove ovaries and fallopian tubes for women with one of these gene mutations. For women with one of these, we would recommend consideration of a risk-reducing hysterectomy to remove the uterus due to risk of uterine cancer, very high risk of colon cancer with an APC gene mutation, and thus risk-reducing colectomy is considered. With a CDH1 mutation, very high risk of stomach cancer and risk-reducing gastrectomy, removal of the stomach, is considered. And here is just a list of other genes for which there are targeted screening approaches that are specific to cancer risks with these specific genes there. So a lot of work has been done recently, particularly earlier this year, with some very important papers that have estimated the magnitude of breast cancer risk with inherited pathogenic variants or mutations in specific genes. This was the Breast Cancer Association Consortium study in the New England Journal of Medicine of thousands of women. And what was found here was looking at lifetime risk from age 20 to 80, the absolute risk. Now remember that the average US woman has a risk of about 10 to 12%. The estimated lifetime risk with a BRCA1 mutation, a little above 50% lifetime chance of developing breast cancer. With BRCA2, about 45% or thereabouts. PALB2, which is close to BRCA2, in that similar range of about 40%. And we think of these as the high penetrance genes, close to a 4 to 5-fold increase in risk. We then see a group that we consider the moderate penetrance genes. So genes like CHEK2 here in orange, ATM in yellow, that are ones that increase the risk by about double, about a 2-fold increase in risk in range of 20 to 30%. And then there are some that specifically increase the risk of hormone receptor negative or triple negative breast cancer. Those include BARD1, RAD51C, and RAD51D with these dotted lines. So you get a sense of what the magnitudes of risk are and how we might adapt our care for these patients to the risk levels. I will say that risk does vary a lot between carriers of these genes, and you might see families where the risk looks much higher or much lower. We think that's probably due to other inherited genes that may play a role. But these are the average risks that we cite to patients if we don't know anything else except for the fact that they do have an inherited mutation in one of these genes. So there are very specific guidelines for women with breast cancer associated gene mutations. And here you can see those from the National Comprehensive Cancer Network that list genes according to their risk level, their estimated absolute lifetime risk. So for the highest risk gene, TP53, risk greater than 60%, we recommend very early MRI at the age of 20, mammogram around age 30, and we do discuss preventive mastectomy as an option. Similar with BRCA1 and BRCA2, which are also high-risk genes. Sometimes in those recent studies, we see lower risks in range of 40 to 50, older ones say greater than 60, which is the number that we're looking at here. So it's somewhere in that range. And with BRCA1 and BRCA2, recommend MRI starting at 25, mammogram at 30, discussing the option of prophylactic mastectomy. For the other high-risk breast cancer genes, PALB2, PTEN, CDH1, we discuss mastectomy as an option. For the lower risk genes, notably ATM, CHEK2, NF1, and several of these moderate penetrance triple negative breast cancer genes, we do recommend MRI for some of these based on family history, but we do not typically discuss prophylactic mastectomy. There really isn't enough evidence, and typically the sense is that the risk is not high enough to warrant this. That, of course, can be individualized on an individual patient basis, but that is what the guidelines say about these various genes. So what do we do in terms of modifying our surgical treatments based on genetic testing results? Well, pre-diagnosis for women found to carry a mutation that elevates risk of breast or ovarian cancer, we do talk about prophylactic surgery in terms of breast and ovaries and fallopian tubes, uterus as well. For males or females, in some cases, we will talk about colectomy or gastrectomy. Again, those are very rare and only for very high-risk genes. Post-diagnosis, we will think about a more extensive treatment surgery. For breast cancer, the discussion would be between lumpectomy and unilateral mastectomy, or unilateral mastectomy rather, versus bilateral mastectomy. For colorectal cancer, we might be thinking about total colectomy versus a less extensive surgery. That might be for a syndrome such as Lynch syndrome that gives a high risk of colorectal cancer. And it's important to note that the surgical urgency really differs by the alternative screening approaches. And so if there's a very good screening approach, we might think of more extensive surgery as an option as opposed to a recommendation. And this needs to be discussed carefully with patients. So for example, with breast cancer, we have a very good alternative screening approach to prophylactic surgery, namely MRI and mammogram. And so that has to be considered to be a standard and appropriate option, with mastectomy an alternative that is also reasonable but not required. With ovarian or fallopian cancer, unfortunately, we have no good screening, and so surgery really is our default recommendation. When we think about radiation therapy these days, there is also taking genetic results into account. And I'll give two interesting examples that come up a lot in practice. One of them is the rare TP53 germline mutations or pathogenic variants, which give a person Li-Fraumeni syndrome. This is very rare, but we see it sometimes. And there had been some older studies that had suggested that the risk was very high that if you treat these patients with radiation, you will cause a sarcoma or a second cancer in the radiation field. This was a very small study, only 6 patients, and reported a very high risk, a 33% chance of getting these new cancers in the radiation field. But fortunately, there have been some more recent studies in 2020, a bit larger, never very large because these patients are rare, that did report significantly lower cancer risks of about 6 to 16%. So the consensus when a patient has an inherited TP53 mutation or Li-Fraumeni syndrome has been that we should try to avoid radiation therapy if we can, but not totally contraindicated if needed. And again, try to minimize diagnostic radiation if we can. A different example, though, is ATM. Now, ATM gene mutations are common. These are much more common than Li-Fraumeni syndrome. You might find ATM in 1% of breast cancer patients. We might find carriers being 1 in 200 or so, so really quite common, whereas Li-Fraumeni is more like 1 in 30,000. So a frequent question that arises with ATM is whether it's okay to use treatment radiation. We know that homozygotes, people who get an ATM mutation from both parents, have a different syndrome, ataxia-telangiectasia, and they have significant radiation sensitivity. As I mentioned, the heterozygotes with only one mutation are quite common, about 1% of breast cancer patients. And it's important to note that studies have been done and truly have not shown convincing evidence of harm from therapeutic radiation in these patients. And so the guideline consensus is that we should not withhold radiation therapy from ATM heterozygotes, people who have only one ATM mutation. And that does come up often. It is important in the treatment of their breast cancers. I want to talk about a special example of systemic therapy that is increasingly tailored to genetic results, and that would be the PARP inhibitors, poly-ADP ribose polymerase. As we know, this is a figure that goes over the different mechanisms of DNA repair in humans, single-strand break repair, PARP1 being an important protein there, double-strand break repair being many of the proteins that we know about, the genes that we know about involved in cancer risk, BRCA1 and 2, PALB2, ATM, CHEK2, and others. And again, some of the other genes we've talked about today, mismatch repair being the Lynch syndrome genes and others. So PARP inhibitors work by the principle of synthetic lethality. And the idea here is that if you have 2 pathways, let's say 2 DNA repair pathways, maybe protein A would be PARP1 and protein B would be BRCA1, and they're both working, a cancer cell that is damaged by chemotherapy or something else will be able to repair the damage to its DNA and survive. And since these are essentially backup pathways, if one is knocked out, but if either is still working, the cancer cell can still repair its damaged DNA and survive. But if you knock them both out, so for example, a BRCA1 mutation carrier where that gene is already down, and then you knock out the other backup pathway with PARP1, then you have an inability to repair the DNA damage and you have cancer cell death. That is the principle of PARP inhibitors and the reason that they've been very successful in the treatment of patients with inherited BRCA1 and 2 and other gene mutations across a range of different cancer diagnoses. One incredibly important trial from this year was the Olympia trial that looked at early stage breast cancer patients with inherited BRCA1 and 2 pathogenic variants or mutations who were at high risk for disease progression, and those who were assigned to 1 year of PARP inhibitor, olaparib adjuvant therapy after completing chemotherapy, had excellent 3-year invasive disease-free survival without their cancer coming back at 86% versus 77% among those who didn't get the PARP inhibitor. So this is a big difference shown up early on in this trial and bodes very well for long-term trial results. The drug was very tolerable. Few patients stopped the PARP inhibitor due to side effects. And this really is the first evidence that a germline targeted therapy, a PARP inhibitor, may improve the cure rate of a common cancer, breast cancer. This is truly a game changer for germline genetic testing. It's incredibly exciting. And shortly after presentation of this trial last June, the American Society of Clinical Oncology and National Comprehensive Cancer Network practice guidelines did endorse BRCA1 and 2 genetic testing for all patients who would have been eligible for participation in the Olympia trial. That generally would be breast cancer patients with stage 2 to 3 disease, ER/PR positive and HER2 negative, or else triple negative, ER/PR and HER2 negative. So that's a lot of patients and really is pushing us into the realm of near universal genetic testing of breast cancer patients with all of its exciting opportunities and its challenges. So should we in fact test every breast cancer patient? This is an argument that we've heard often in recent years. There are both pros and cons. Pros being that pathogenic variants or mutations are relevant for treatment, increasingly so, as I mentioned. But multiple gene panels that get used more often, as I showed, often do contain clinically irrelevant genes, and this may be a problem for patients and doctors. We saw that this may enhance the precision of cancer treatment by being able to select PARP inhibitors and choose other therapies. However, I'll show you evidence that it may worsen health disparities in terms of test access, results, and interpretation. We know that pathogenic variants do guide secondary cancer risk reduction. A person might choose to have prophylactic surgery together with a treatment surgery or in sequence with it, but some studies do suggest inappropriate use of such surgery. We know that the testing results are relevant for the care of unaffected relatives, but there is uncertainty in terms of how we should implement genetic testing of relatives, what we call cascade testing. We know that all guidelines do miss some patients, which might argue for just testing everybody, but the reverse here is that guidelines capture most patients with high penetrance, really striking pathogenic variants like BRCA1 and 2 or PALB2. And then a pro would be that some studies show little evidence that clinicians are treating patients incorrectly based on these results. Other studies, though, not so much. And there's been some evidence of misinterpretation of results like variants of uncertain significance, which are subtle changes that should not be acted upon, or clonal hematopoiesis, an early malignant process in a peripheral cell that might be mistaken for an inherited mutation. So there are different points of view about whether we should test every breast cancer patient. The National Comprehensive Cancer Network says no, we should continue to risk stratify based on personal and family history and treatment relevance. The American Society of Breast Surgeons says yes, test every breast cancer patient for at least these 3 high penetrance genes, BRCA1 and 2 and PALB2. My own opinion is that it is probably less important that we worry about this than that we be sure that we get everybody who has a significant likelihood of a genetic mutation and really focus on optimizing testing and results going forward. So what happens when we test patients broadly, as we're beginning to do? Well, this is a result from the study that I showed early on, where we were looking at patients enrolled in cancer registries in the states of Georgia and California from the time period of 2013 to 2017. And I told you that over this time, more and more patients were tested for a broader array of genes because we're able to do that now. And so the point here is that what we found was that there was a slight increase in these solid solid colors in finding pathogenic variants or meaningful mutations in the genes that were tested as we tested more genes. But these crosshatched rows here are these variants of uncertain significance. So findings that we wouldn't actually have cared about clinically because usually they aren't important. They're subtle changes which will ultimately be reinterpreted as normal. 90% of the time they turn out to be normal. And yet we find a lot more of them as we test less familiar genes in these patients. So we see this again graphically represented here by race and ethnicity, that pathogenic variant rate hasn't increased very much, maybe a little bit. And also we are testing lower risk patients. So the overall rate stays about the same. But you do see this rapid rise in these pesky variants of uncertain significance. And the other thing we see that's a bit alarming is a separation in the curves. So more of a gap between patients who are not white. So we see Asians and Black patients having a higher prevalence of these variants of uncertain significance than non-Hispanic whites. I don't think this is biology. I think this is the fact that most of these genes were first sequenced and discovered in Europeans. And so when we see a normal variation, we tend to call it a variant of uncertain significance in other racial and ethnic groups because they just haven't been tested as much. That's a problem when this racial VUS gap widens with testing more genes as we're seeing. And there may be implications for care disparities in the care of non-Hispanic white patients, which is certainly a problem. And I say that because there have been some studies that have suggested there may be some issues in terms of the management of genetic testing results. We published last year a study in JAMA Oncology where we looked at breast cancer patients and whether they got various treatments according to their genetic testing results. We found that compared to patients testing negative, reassuringly, at least in this study, patients who had a variant of uncertain significance, which should not prompt a change in treatment, fortunately got about the same treatment. So that was encouraging to us. However, we did see some slightly unusual treatments based on pathogenic variant or harmful mutation results in BRCA or another gene. We saw a lot more bilateral mastectomy in BRCA rather than negative testing patients. That's fine, that's part of the guidelines. But a lot of the other patients were also getting bilateral mastectomy. And as we saw, that isn't necessarily indicated for patients with lower risk gene mutations. What we did see that worried us was a much lower rate of radiation therapy among these patients, particularly BRCA mutation carriers, suggesting that there may have been withholding of radiation therapy for fear of causing cancers in these patients. And as we saw, the guidelines generally don't recommend that, except for potentially thinking about it for TP53, which are very rare. And we also saw more use of chemotherapy among patients who in this case had very low risk breast cancer, low Oncotype DX recurrence scores. So again, suggesting that there may be some acting on the results of these germline tests that may perhaps be more than is needed. In a different study by a colleague at University of Pennsylvania, Dr. Susan Domchek and colleagues, there was actually a survey of patients who had these different results of variants of uncertain significance and pathogenic or likely pathogenic mutations in these different genes, ATM, CHEK2, and PALB2. And the patients who did in fact undergo risk-reducing salpingo-oophorectomy were asked if their doctor had recommended it, either as an active thing they should do or had discussed it as an option. And really the only case in which it should have been discussed as an option is for people with a PALB2 pathogenic variant. For all of these other patients, we really don't recommend that. And so it was rather alarming to see rates so much higher than 0 for provider recommended or discussed as an option for oophorectomy. And thus, I think this does indicate that there's a need for education. There's a need for patients and doctors knowing more about what to do when they get one of these genetic testing results. I will also say that we know that there are some implementation challenges in terms of referral and counseling. We did some work with surveys of patients and doctors, and in terms of looking at patients who were indicated for genetic testing, we find that they are not always referred. And so when we talked to patients who had a strong reason for genetic testing, we found that a quarter of them who were not actually tested as they should be, it was because they said, my doctor did not recommend it. I thought it might be expense, but that was not the most common reason. It was about recommendation. We saw a similar result in this study of looking at patients and whether they got any genetic counseling, formal counseling with a formal directed visit, which is what we'd like to see, particularly for someone testing positive versus physician directed versus no counseling. These were patients who actually wanted genetic testing. And so, in this study from a few years ago, it was not great to see that a lot of them didn't get it. Those numbers of formal counseling do get better as we see patients testing positive, but again, we'd like to get the rates up even higher. I will also notice that there is a clear opportunity for cascade genetic testing. So for testing relatives of patients with genetic mutations, this was from an article last year led by Ken Offit at Memorial Sloan Kettering. We wrote an editorial where what they estimated was the more relatives you test, the faster you're going to identify all of the mutation carriers in the population. And so, for example, let's say you only tested first-degree relatives of cancer patients, it would take a really long time to find all the carriers, upwards of 10 years. Whereas if we went and tested second and third-degree relatives too, you can see on this orange curve that we could find all the carriers in half the time, maybe only 5 years. And this goes along with other work by our Stanford colleague, Gary Ladebaum, who has shown that it's very cost-effective to get a lot of relatives tested. You save a lot of lives that way, not surprisingly. We've shown in some other work that there is really a shortfall in genetic testing of relatives. We actually did a study where we asked patients if they had encouraged their relatives to test. Among patients testing positive versus VUS or negative, we did see a difference with 80% of patients testing positive say yes, they had encouraged their relatives versus a lower proportion testing negative, which is fine because there isn't typically a good reason to test people if the relative tested negative. But we see a drop off here, even among those with relatives who tested positive, only about 30%, 30 to 40% actually had a genetic evaluation or genetic testing. And that's really something that needs to change so that we can serve the relatives of these patients better. I think one thing that is beginning to help us is new approaches to genetic testing delivery with telehealth, as is shown by these studies, point of care study presented a few years ago in pancreas and metastatic prostate cancer, and a recent study of delivering by telehealth. And of course, we all know that with the COVID-19 pandemic, it's been a bit of a natural experiment in needing to bring this online. And I will say that I think for genetic counseling and testing, telehealth works very well for most patients and their relatives. So I think this is a positive move. Another problem that we have, again, is these VUS and needing to get better at VUS reclassification to benign, which 90% of them will be. This figure shows the timeline from a single laboratory. This happens to be Myriad Genetics, but could be any of them. Discovery of BRCA1 and BRCA2, hereditary breast ovarian cancer in the 90s. And we see lots of different strategies that have evolved to begin to resolve uncertain results more quickly over time. And that's shown in another study with the time to an amended report. It used to be back in 2006, it would take 2.5 years to get a VUS resolved to normal or harmful. Now that rate has gone way down. But of course, this is a problem to keep up with as we test more and more genes. So I'd like to conclude with research priorities for this field. As I've mentioned, I think that getting better at reclassifying uncertain results, variants of uncertain significance, particularly in racial and ethnic minorities, is a key priority. So is more precise and better personalized penetrance estimates, understanding if risk might be as low as 20% versus as high as 60%, with given gene mutations really might influence what a patient chooses to do. In terms of outcomes, we need to know more about the impact of genetic testing results on treatment selection and mortality, and on the use and outcomes of screening and prevention interventions, so we can get better at what we deliver. And further care delivery metrics need to be more testing of indicated patients, such as ovarian cancer patients and their relatives of all cancer patients. I do think we need novel approaches to delivering cancer genetics expertise as our patient base whom we test keeps growing. And I do think telehealth is very promising. And I think we also need gene-specific decision tools to help patients and doctors when they get a result about what to do with it. So I will stop here and thank you very much for your attention.